Good afternoon, good morning, and good evening to everyone. We welcome you all, particularly those of you joining from far away or at late or early times. Thank you for joining this EPI-WIN Wednesday webinar on the topic of ready to respond to an outbreak of Ebola and Marburg disease hosted by WHO EPI-WIN. For those new to WHO EPI-WIN, this is the WHO Information Network for Epidemics for Science and Knowledge Translation in Health Emergencies. With these EPI-WIN webinars and associated EPI-WIN digests, our goal is to translate science in accessible, understandable, and relevant ways for evidence-informed actions and decisions in health emergency preparedness and response. Today, we have a great panel to discuss Ebola and Marburg disease. I will give you a brief introduction of speakers, which speakers can add to. Welcome will be done by Dr. Sylvie Briand, Director of Epidemic and Pandemic Preparedness and Prevention at WHO. Then this will be followed by speakers like Dr. Nedret Emiroglu, Director at Country Readiness Strengthening for Health Emergencies in WHO, followed by Mrs. Victoria Willett, IPC Technical Officer in the Health Emergency Program in WHO, and then Dr. Folasade Ogunsola, Vice Chancellor at Lagos University Teaching Hospital and co-chair of Infection Prevention and Control of the Guideline Development Group for Ebola and Marburg disease, and then Director Elizabeth Katwezi, IPC specialist at the Ministry of Health in Uganda. Interpretation services will be available for this webinar in Arabic, French, Spanish, and Portuguese, plus artificial intelligence powered interpretation will be provided in Chinese, Russian, Hindi, and Swahili. Swahili is in the other booth. So let me just do some housekeeping. This webinar is being live streamed on the EPI-WIN YouTube channel. We will provide the link in the chat. The webinar is being recorded, and afterwards the recording will be available from our website. The address will appear in the chat. And we invite you all to post your name, location, and organization in the chat box. We would love to hear where you're joining us from. Please add any questions you may have to the question and answer box, not in the chat, so we can more easily keep track of them. So without any further ads, I will hand the floor over to Sylvie Briand for the welcome to this EPI-WIN webinar.
Okay, thank you very much, Agnese. And first of all, I would like to welcome you to this new EPI-WIN webinar. Today, we will talk about infection prevention and control for certain outbreaks, such as Ebola and Marburg, that are due to filoviruses. And this topic is very important. First, the topic of IPC is important, infection prevention and control, because infection prevention and control saves lives and a lot of lives. So it's very important to take care of IPC, especially during outbreak response. In previous years, I mean, when I started at WHO, at least IPC was mostly directed to protecting the patient. And this is very important, as you know, because patients can be infected in healthcare facilities. During Ebola outbreaks, we have seen in the past people being infected while receiving unsafe injection. It was the case also for Marburg disease in Angola, for instance, in 2005, if I remember well, the year. And so it's very important, in fact, to implement IPC to protect the patient and make sure that the outbreak doesn't spread through the community, having the healthcare facilities as a hub for transmission. But more recently, we have also paid a lot of attention to protect the healthcare workers, the nurses, the doctors, and other frontline responders, because they can also be infected during an outbreak response. And it's very important for them to know how to protect themselves. Why? Because first, if some health responders are affected at the beginning of the outbreak, then you have much less people to take care of the patient because they also need to be taken care of and they cannot provide care in their healthcare facilities. But also because when you have in certain remote places, one nurse or one doctor infected and then died, then in the long term, you have a huge population that is uncovered or doesn't have access to care. So IPC is important for the short term to respond to the outbreak, but also very important in view of strengthening health system and making sure that the health workforce that is so precious is not wasted or lost during an outbreak. And so this is a very important point as well, for which we need IPC, good IPC guidance and regularly updated IPC guidance. Finally, I just would like to say that this field is also very much evolving because we have challenges, of course, but for instance, if you just look at the PPE, the personal protective equipment, you know, those people who are like in space suits, we have, there is a lot of innovation and we try to have PPEs that are lighter, easier to put on, maybe reusable, and also disposable in a way that is safe for the environment. We are also making a lot of progress in humanizing the care during this outbreak. And for instance, we have put in recent outbreak the name on the PPE so that a patient can know who is taking care of them. Also, you remember certainly the images of the Ebola bubble that were developed by NGOs in recent outbreaks. So this field is evolving rapidly. And I think it's very important for all of us to be aware of the changes and what is new and how we can improve IPC during outbreak response. So with this, I'll give back the floor to Agnese. And again, welcome to this EPI-WIN webinar. And thank you for being with us today. Over to you, Agnese.
Thank you, Sylvie. Thank you for this amazing opening. And I'm glad to give the floor now to the Director of the Country Readiness Strengthening for Health Emergencies, Nedret Emiroglu. Over to you.
Thank you very much, Agnes. And I also welcome you to this webinar, which is critically important to support the work of the countries to strengthen their capacity for preparedness and readiness response related to infection and prevention control capabilities as we respond to many outbreaks. And it's extremely timely that we remember that it will be the 10-year, unfortunately, in January 24, since the devastating outbreak of Ebola disease in West Africa, where we have faced many deaths, which was over 11,000 people. And actually, as Sylvie mentioned, it was not only the patients. There were several hundreds of health and care workers, which is a situation we unfortunately repeatedly observed during the COVID outbreaks, pandemic. So, what we try to support countries is to keep the critical health and care workers and patients safe while implementing the IPC measures consistently and rigorously. And I don't need to remind you that IPC is a cross-cutting area which requires collaboration among different actors. So it is increasingly, we are looking into the IPC, getting not only at the health facility level, as well as at the community level, in engaging the communities and together with the people. Another strong observation from both Ebola, Marburg, as well as COVID. So I'm happy that we will discuss the guidelines today, which is looking into the recommendations for early targeted and effective response activities. And even though the guidelines are focusing on healthcare facilities, but it's also taking and considering a broader context of health delivery in the community setting, which is, again, extremely important. And I hope that this is going to help the member states, decision and policy makers, partners, and all stakeholders to be able to implement the IPC measures to protect the health and care workforce and the patients, and ultimately will save lives. So thank you very much from my side. I'm also looking forward to the discussions. Back to you, Agnes.
Thank you, Nedret. Thank you, Director, for this amazing opening. I just want now to give the floor to Victoria, with the IPC Technical Officer for in the Health Emergencies Program at WHO. And I kindly ask Victoria also to introduce the next two speakers as she's been organizing this webinar with our team. Thank you. Victoria, over to you.
Thank you so much, Agnes. Will I have control of the slides, or someone can move the next slide, please? And the next one, and one more. So just to introduce myself, I'm Victoria Willett. I'm an IPC Technical Officer with the Health Emergencies team, the Country Readiness and Strengthening Department. I work under Dr. April Baller, and have been in collaboration with my colleague who is also online, David Dixit, have been working on the development of this guideline for the past couple of years. We also have online today Professor Sade Ogunsala, who, as they mentioned, is the Vice Chancellor of the University of Lagos, but also was co-chair of the Guideline Development Group for developing this guideline. And then we have Dr. Elizabeth Katswegi, who is the Infection Prevention Control with the Ministry of Health in Uganda. And she's going to share the experience that Uganda had last year, almost 1 year ago to date, actually, when they were dealing with an outbreak of Sudan virus, Ebola virus in Uganda, and actually started implementing these recommendations. So with that, if we could go to the next slide. So objectives today, this is the newly published Infection Prevention and Control Guideline for Ebola and Marburg disease. The link to it is below. It's also available on the Magic App platform for those of you who are familiar with that. And what we really want to do today is promote awareness of this new guideline. It was just published in August. We want to discuss the changes and new recommendations, highlighting on specifically some of the new recommendations. And then we want to have the opportunity to share the experience of Uganda in implementing these recommendations during an outbreak response, and hopefully have time for some questions and answers after this. So why do we need a new guideline? Well, since the West African outbreak, which Dr. Emiroglu referred to, there's been a lot of other numerous outbreaks in several countries, and we've learned a lot of lessons. We've also had a lot of new developments in terms of vaccines, in terms of the way we set up Ebola treatment centers or Marburg treatment centers, but we still continue to see some suboptimal IPC practices during these response efforts for outbreaks. And there seems to be a lack of a standardized approach for infection prevention and control between countries and partners. And sometimes this leads to confusion amongst health and care workers, and it can increase the risks for those health and care workers. So we recognized that we really needed an evidence-based guideline to support countries, member states, partners when responding to these outbreaks. Apologies, a bit of a cough today. So previously, there were 3 documents, which are posted here on the left side of your screen, that were rapid advice or interim guidelines that had been published between 2014 and 2016. What we did is, with our guideline development group, we have looked at all of these documents, and then we've replaced them with the new published guideline from August of 2023. Recommendations from these previous documents were carefully reviewed, and some were incorporated into the new guideline. Next slide, please. So within this guideline, we have about 9 recommendations that were brought forward from the previous guidelines. And we also have 11 new recommendations and 10 good practice statements. Now, what we did find, we did use a evidence decision and grade process. So we gathered over the last 2 years a guideline development group that came together and looked at all of the literature that was available for the questions that were developed to base our recommendations on. We also conducted a mixed methods study where we surveyed a number of health and care workers that had participated in caring for patients in various outbreaks of Ebola or Marburg. And we gathered their feedback on what was important to them, what they valued in the outcomes to help guide the decision-making of the GDG, especially when there were areas where we had low evidence. So in the end, we ended up with the recommendations. And what I do want to highlight is many recommendations are conditional, but what this means is that there are certain criteria where they can be adapted based on the conditions that were identified to the context and the resources in that setting. And that's an important context that for us all to keep in mind, and why we really need to make sure that you read the guideline in its entirety. And we also have a number of good practice statements. And these are actionable statements that support the conditional recommendations and also highlight areas where it was felt this is something that should be done, even though evidence may be indirect. So as I mentioned, this was a 2-year process, and we're really happy to present it now. And with that, next slide, please. I think we will turn it over to Professor Ogasala, and she will walk us through some of the highlights of the new guideline. So thank you very much. Over to you. Sade, you're muted.
I apologize.
There we go. Thank you.
Thank you very much. Good day, everyone. In the next 8 slides, I will be highlighting key concepts from the new guidelines, as we cannot go into all the details of the recommendations. And these highlights will cover a variety of topics ranging from the IPC ring strategy, PPE use, cleaning and disinfection, with special attention to recommendations on not spraying, as well as on health and care worker exposures, which are all important aspects of infection prevention and control. As we will only present the important concepts in the slides and not the actual recommendations, we strongly encourage you all to read the full guidelines. It's important when reviewing these recommendations that you take time to consider the remarks and the implementation considerations that are detailed within the guideline to fully understand the recommendations. Next slide. The next slide is about the IPC ring approach, which is a new recommendation. We talk about applying the IPC ring approach once a case of Ebola or Marburg is identified. This is a strategy in which rapid, intensive, and short-term IPC support is delivered to healthcare facilities, the community, and households in any settings in areas of active disease transmission to help to break the chain of transmission and prevent healthcare-associated infections. Essentially, we ring-fence the case of EVT around with bundles of IPC interventions. So once we identify a case at the healthcare facility or a high-risk setting, area or associated healthcare facilities are identified, we start a bundle of interventions that are implemented. And these include decontamination of affected healthcare facilities and or households, rapid assessment of IPC measures at healthcare facilities using a standardized tool, e.g. the IPC Ebola and Marburg scorecard, followed by development of an improvement plan. We also have IPC wash supply kits distributions. We brief health and care workers, give them briefings on IPC, and then carry out a risk assessment of health and care workers who may have been exposed to Ebola virus or the Marburg virus. This is then followed up with regular supportive supervision and mentorship, as well as periodic reevaluations. Next slide. The guidelines continue to highlight the ongoing importance of hand hygiene, including the 5 moments of hand hygiene, as well as during the process of putting on and taking off PPE. The hand hygiene recommendation is not new, but we recognize how critical it is to safe patient care and preventing infections in health and care workers. Next slide. Another highlight that is seen over several recommendations in the guidelines is the rationale and appropriate use of PPE, depending on the setting, which is linked to the risk of infection in the health and care workers. For more details on exact PPE that should be worn, we will refer you to the guidelines, but I want to mention some key points. During screening, if you are at least 1 meter distant and you're using a no-touch technique, then no PPE is required. I'll say that again. During PPE, if at least 1 meter distance and a no-touch technique is used, then no PPE is required. But if you're less than 1 meter distance or touch cannot be maintained, the PPE listed here should be worn, including a medical mask and eye protection, fluid-resistant gown, and 1 pair of gloves. Other controls, such as placing a table to maintain the minimum 1 meter distance, are also important because most tables are about, a meter plus in length. Next slide. Another new recommendation. We have 2 good practice statements that cover the area of patient placement and highlight the need for single rooms with dedicated toilets for patients. In addition, we strongly discourage cohorting between suspected and confirmed patients wherever possible. Not only the patient's physical health, but also their mental health needs to be considered. And isolation facility areas should include safe ways for visitors and family to interact with the patients. The importance of patient well-being and inclusivity of special populations such as children is also highlighted in the guidelines. Next slide. There are several recommendations in the guidelines against spraying of disinfectants, of which chlorine is the most commonly used one. Overall, the WHO discourages the spraying of people or areas where people are present, including upon leaving a treatment center, the environment, as well as during dead body management. Next slide. Next slide. There is a strong recommendation, which is a recommendation against spraying people, such as during various steps of the PPE removal process. In addition, spraying should not occur where other people are, e.g. where other patients are. This concept is not new, but we have formalized it in this guideline. Another new recommendation, next slide, please. We've mentioned in prior slides about how spraying of the environment is not recommended. Rather, wiping is the preferred method over spraying. For the recommendation on cleaning and disinfection, we would like again to highlight that wiping is preferred over spraying. And to remember that regardless of method, cleaning of surfaces should be followed by disinfection as required, and adequate contact time of the disinfectant of the surface must be ensured. Next slide. This is another new recommendation. In the event that a health and care worker has a potential exposure to Ebola or the Marburg virus, they should be assessed, and if deemed to be exposed to not only these viruses, but other blood-borne viruses such as HIV, hepatitis B, and hepatitis C. If there has been an exposure to Ebola or Marburg virus, it is recommended that to exclude them for work for 21 days. This is a conditional recommendation because it's also important to consider risk if they were allowed to continue working versus operational considerations, such as can a facility stay open if the workers cannot work? In summary, sorry, one more slide. Sorry.
I think go back one slide, please.
Yes, go back one. Thank you. There's a missing slide. Okay. That's good. Thank you very much. This recommendation builds on the importance of dignified and culturally respectful burials while maintaining the safety of those involved in the process through the use of standard and transmission-based precautions. The WHO suggests that spraying of the deceased with chlorine prior to placing them in a body bag is unnecessary. Next slide. Next slide. Thank you. In summary, many practices used in past outbreaks of Ebola and Marburg disease are ingrained, although they're not supported by evidence or principles of infection prevention and control. We have new experience since then, as well as have conducted updated literature reviews to help answer key questions. This document is a first step towards the use of standard and transmission-based precautions for Ebola and Marburg disease, though it does still include disease-specific recommendations, and many recommendations remain conditional due to the limited numbers of high-quality evidence. During the guideline process, research gaps were also identified, which will help us in the future to strengthen our recommendations. And we also have a call to action for research underway. Thank you very much. I now pass this on to the next speaker.
Thank you so much, Sade, for going over those highlights for us. And we'll now go over to Dr. Elizabeth Katswigi from the Ministry of Health in Uganda. Thank you, Elizabeth.
Thank you very much, Victoria. I'm going to be sharing our experience from the recent Sudan Ebola virus outbreak, which we responded to from 20th September 2022 to 11th January 2023 when it was declared over. Next slide, please. So at the beginning of this outbreak, we had a guideline that we had been using as a nation, And this guideline for Ebola and Marburg was from 2015, but we realized that it contained some practices that had been since changed, like Prof. Sadi has highlighted, issues around spraying and other practices. So earlier on in the first 1 to 2 weeks of the outbreak, we were able to work with the World Health Organization and other partners to review this guidance, and we produced standard operating procedures, about 16 of them for the key IPC practices, and these were adopted and approved by the Ministry of Health through the response pillar structures. And this is what we are utilizing in this current outbreak based on the draft global guidelines that have been highlighted. Some of the things that worked very well, the use of the Ebola IPC Healthcare Facility Rapid Assessment Tool, the scorecard, the implementation of the Ring IPC strategy. I'll be talking about this more shortly. And we're able to get disseminate the information through several trainings, most of which were virtual, webinars and others, and some facility mentorships, especially in the districts that were affected by the outbreak, where we had teams on the ground try and disseminate this guidance. Some of the practices that were observed to be difficult to change, even when we had information and passed on the standard operating procedures, practices around decontamination by spraying. This was especially in during the Ring IPC strategy, like in decontamination of homes, but also ambulances and some other few areas, although this was noticed to come down as we continued with the education. Utilization of foot bath outside the ETU, that is outside the doffing process, including entrance into hospitals and others. This was also one of the practices, utilizing chlorine and then disinfecting before cleaning. The other was the happy shower, where we have patients that have been declared cured of Ebola taking a shower using chlorine. Also, it was difficult to change the practice of decontamination of reusable items, especially those used by the Ebola suspects and confirmed cases, even when they are not heavily soiled, especially linen. The key challenge to implement this new guideline was we're implementing this in the setting of an outbreak where everyone was up and down, and we needed a lot of speed to reach out to cover a larger area, but with continued education, especially on the online sessions and mentorship with the teams on the ground, we're able to have some of the practices that have been highlighted here changing, although some persisted up to the end of the outbreak. Next slide, please. This is just a highlight of the use of the assessment scorecard, highlighting some assessments that had been done. We were able to see up to more than 6,000 facilities, and we realized an increase in the improvement of the performance. When we started, we had less than 20% of the facilities above 80%, but with repeated use of the scorecard, working with the teams to develop action plans and following up on the action plans, although it may not have been as frequent as recommended for the facilities that are lower than 50%, where we needed to do more frequent visits, but at least priority was made for those facilities, and we had external support towards these facilities, and were able to observe improvements. We were utilizing ODK to collect the data and visualizing it using a Power BI dashboard, where we had access to the platform by the Ministry of Health and the different supporting partners, so that we're able to look at the performance and give quick response to the affected facilities that were scoring low. Next slide, please. Just to highlight briefly about the IPC ring that has been talked about before, strategy. This was an approach that we embraced. We had training materials, SOPs, and practical exercises for demonstration, especially in the 5 areas that are highlighted in the graph on the right, where we had most of the cases, and in the capital in Kampala, we were able to perform 32 IPC rings, together mainly the IPC team, the hygienists, support from surveillance, risk communication, and community engagement teams although we would not go out as a team all the time because we didn't have this structured team, but we were able to get support from the different members. Some of the best practices observed in the ring strategy are decontamination practices improved as we went ahead in the outbreak to follow new recommendation. There was less spraying, more utilization of wiping, challenges around what to do with water houses, which were most of the houses we encountered since the outbreak was mainly in the rural setting, but as much as possible tried to clean before decontamination. IPC assessments were being done, maybe less on the exposure assessments to healthcare workers. Supplies were also being given, not as a standardized kit, but as much as possible priority given to the PPEs and the hand hygiene supplies. And after the outbreak, we're able to prioritize this as one of the after action review activities to ensure that we build ring teams in some of the districts so that we're able to have that team to start with in case of a future outbreak as we mobilize for such support. Let's go on. Next slide, please. Thank you. For the healthcare worker exposure assessment, this is one of the strategies that we also picked up. We're able to digitalize the tool shown here, also on ODK. Active reporting was a bit later on in the outbreak, but most of the patients, most of the healthcare workers that were identified from the surveillance team as part of contact tracing, but also some that were exposed or infected. We tried to assess utilizing this tool to ensure that we look at any IPC lapses that led to exposure and prevent further exposures. Some challenges, especially around the healthcare workers who were infected, because these were transferred to be treated in one center, not necessarily the health facility. So we may have lost some information there, but we're able to actively investigate some of the healthcare worker infections utilizing this tool. Next slide, please. Next slide, please. Thank you very much. This is just a pictorial highlighting some of the key practices and activities. On the left, you can look at some webinar flyers we had. We're looking at the outbreak and supporting. And finally, as we move forward for readiness and preparedness, we are working to develop and standardize our IPC guidelines, both for routine and for outbreaks included in the guidelines, making reference and adopting the recently published WHO IPC Ebola guidelines, so that in future we have a guideline that is already Ministry of Health approved, disseminated, and in use, and orientations have been done for healthcare workers, so that we have these guidelines standardized already before the outbreak. And I would like to end by appreciating the Ministry of Health for the support, but also for several partners that supported the IPC response, many of whom I can see on the call here. We appreciate the support. Thank you very much. Back to you, Victoria.
Thank you very much, Dr. Elizabeth, for a very interesting presentation. I think it's really helped us understand the actual reality on the ground of trying to implement these recommendations. And even though we have guidelines, it's always interesting to try and actually bring them into practice. So we are now going to take a few minutes to answer some questions. And we have a number of questions in the Q&A with people asking about why we're no longer recommending spraying. And so I wondered, Professor Sade, if you would like to take that and speak to that. We had a lot of discussion during the GDG around this issue.
Yes, thank you very much. I noted that. Can you hear me?
Yes, apologies, I forgot to mute.
Okay. Spraying, the problem with spraying is, one, when you spray, you don't actually guarantee that you're properly covering the surfaces of the human surface. But more importantly, for the health of people, you're spraying into their noses, their eyes, and we already have documents that show that the impact of spraying chlorine on people in terms of respiratory problems in terms of their eyes and problems with their eyes, and in terms of allergy were high. And so and the value and being able to actually determine that you've properly covered and you have not cleaned even before you spray. So there's so many concepts wrong. When somebody comes out, you think that they have, they're coming out of a disease. You don't clean, you just apply spray, which is just done zoom, 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 because we've been in the field and you can guarantee that you've actually disinfected. So there has been no proven thing to show that it is safe, but there's a lot to show that it is unsafe for health. And if it's into the environment, again, the concept of cleaning the environment before you put disinfectant is totally missing. So people just spray, but no evidence that you're actually reaching the organism. So from what we have, the evidence we have so far is that there is more damage done and really no evidence that it is actually disinfecting. But we do know that if you clean, then you apply disinfectant and wipe it off, that we do have improved killing. So I think that is why we're not doing spraying. There really isn't any evidence. And if you think about it, a lot of it, how it developed was people didn't want to move near the person who's come out of Ebola treatment center because you felt that you could get infected. But we know that with all the barriers that you have with the PPE, there's really no problem with wiping. And then wetness all around actually promotes infections in general. So on many points, spraying certainly has less for it. Beyond that, it makes people feel comfortable, but that's not a good enough thing for us to go continue with spraying. Vicky, I hope I explained well. You're muted.
There we go. Couldn't find the button. Thank you. Yeah, that was excellent. Thank you for that, Sade. And I just want to note for the group as well that this is a conditional. So while we have a strong recommendation advising against the spraying of people, especially health workers, with chlorine for all of the reasons that Professor Sade has identified, the actual spraying of the environment is a conditional recommendation. So I just want to emphasize that sometimes, while we know the important thing is to clean, as Professor Sade mentioned, and then apply the disinfectant, wiping is preferred, but we do recognize that there are some situations in some contexts where perhaps there's not enough water nearby, they have to bring the water, or the surfaces may be very porous, maybe a small hut. And in those circumstances, sometimes spraying may be considered, but those should be the last choice. And so we really want to focus on getting people to wipe and first clean and then disinfect as described. I see we have several hands up. Some hands have been up for a while, and I thought it might be nice to hear from our participants. I wondered, Lourdes Oliva, are they able to unmute, Agnes, and speak?
Sorry, Victoria, can you repeat?
Are the participants able to unmute and ask their questions? Because there's several hands up.
Yes, I can allow to talk to, okay, who you want to start with?
Oliva Lourdes or Lourdes Oliva?
Okay, let me start with there then. You're allowed to speak, Oliva Lourdes. Let me unmute you too. Okay, now you need to be unmuted. So you need to press on the button to be unmuted.
Okay. Maybe we'll go on to the next person.
Yes, so
Jesus Ula. I'm probably not saying it right. Oh. I think they're all.
Okay, so Jesus, you are allowed to talk. You need to unmute yourself. Okay, I just allowed to talk to all people who had the hand raised. You need to all unmute yourself in order to be able to speak.
I see Tamori's unmuted, so we'll start with Tamori.
Great.
Thank you very much. Well, don't worry, it's okay. Thank you very much. I'm still quite worried about this non-spraying. Are there alternatives to chlorine? Because really, under the circumstances that we're talking about, whether you're wiping or whatever, you're still exposing yourself. Are there alternatives to chlorine? And I'm thinking you should relook at this recommendation and find alternatives rather than say no spraying. Over.
So there are alternatives to chlorine that can be used. And in the guideline, we actually included a link to an FDA document that lists the chemicals that are effective against Ebola and Marburg virus. But in many countries, chlorine is the most easily accessed disinfectant that we can use during an outbreak. So typically chlorine is used, but regardless of what chemical you use, we still are encouraging that you not spray. The basic principles of infection prevention control are that you clean first with soap and water so that we can remove any physical debris and contamination, and then disinfect. And this should be done with wiping. And I think I'll ask Dr. Elizabeth if she wants to speak to this about the fact that they were able to, it took some work, but we were able to successfully implement this in Uganda. I wondered if you would like to add anything, Elizabeth?
Thank you very much, Victoria. I hope you can hear me. This was also one of the areas where we had a lot of difficulties to change this practice. And for some of the areas, it still continued. From the previous speaker, looking at the difficulties, especially for wiping big surfaces like an ambulance that has transported a patient. But at least for some of the areas like homes which had a cement floor that you can wipe, were able to do this in the healthcare facility setting, but with lots of discomfort and similar expressions from the previous speaker of the difficulty to go around wiping a big surface, the exposure. But we always encouraged proper PPE so that you're able to safely get into contact with the different areas you want to clean and decontaminate. Thank you. Over.
Thank you so much, Elizabeth. And I see a lot of questions still popping up about this. So I'm just going to, our colleague, Dr. April Baller, is also on. April, if you would like to speak, because we also had this experience recently in Equatorial Guinea. If you would want to say a few more words on this, and then we'll move to a different subject. Can we unmute April Baller? Okay, I don't know if we're able to unmute, but I think Elizabeth has spoken to some key points. It is a change in practice. It's different than what a lot of people are comfortable doing, but it can be safely implemented. People wear their PPE during the process, and it works quite well. So we'll go on to, I think, Brian Ogang is ready to ask a question. Can people hear me?
Yes, we can hear you. Brian, we allowed you to talk, and you are unmuted, so you have the floor to speak. We're waiting for your question.
Oh, I think we just lost him.
Yeah, maybe he has some connection issues. So I
Okay.
see also there is April. I don't know if, and I just allowed her to speak. I don't know if she can unmute herself.
I think so. Agnes, can you hear me?
Yes, we can hear you.
Okay, great. So thank you so much. And thanks also to Vicky, to Professor Sade, and to Elizabeth. Great presentations. I just wanted to go back to the question earlier from the colleague, because I think there was a few different pieces to it. There's the time when you need to, you know, previously people use spraying for, there's different activities when you use the spraying. You can use the spraying when you're doffing, in between taking off each individual PPE. You can also do the spraying when you are doing the environmental cleaning. And I think particularly in the context, just to be clear, in the context of doffing, now there is no spraying of the hands in between. What you can use is soap and water, or you can use alcohol-based hand rub. So just to nuance it a bit and be clear that it's both related to persons doing hand hygiene, also when they're taking off their PPE, which they now just need to take off and they don't need to spray it. And then of course, there's the element of the environment, which Professor Sade spoke to, and that can be either within the facility, which is very important to use the cleaning first and disinfectant. And for that, the chlorine works fine. And then in the context of the community, which is often in the households. And for the body bags there, it is possible to do it with the wiping, or as Victoria was saying, in cases where it's complicated, you could also do the spraying. So thank you very much, and back to you, Agnes.
Thank you, April. Victoria, I believe you want to reply.
No, I think we're good now. I think we were going to try to move on to a different question. If Tamori Oyal would like to take this next question, over to you, Tamori.
Sorry, I think it's the old hand. Let me know.
Oh, okay. Sorry.
I'm sorry.
Okay. Yes. And we have one last hand, Martin Williams. If you can unmute yourself. Go ahead, Martin.
I think he either he left or he unraised his hands. There is, yeah, only there are no more raised hands unless Tamori wants to add something.
Okay.
Actually, Anthony Martin had unmuted. I don't know why. He unmuted immediately and then.
Oh, yes, here he is. Martin, can you speak? We can hear you. You are unmuted. I guess there is some issues with his audio. This is why we cannot hear him. I guess he's speaking, but we cannot hear him. Sorry, Martin. If you want to write the question in the Q&A, we will be able to reply.
Okay, and I see Brian's hand is up again. So maybe we'll give Brian one last try, and then I imagine we'll close. Brian, are you able to speak? If you can unmute. Brian Ogang.
Am I registered as Brian? I am not sure if I'm being referred
Yes,
to.
Brian Ivan Ogang. Yes, you. Go ahead.
Oh, thank you. I'm Joseph Omoy from MOH Uganda. Thank you so much for the chance. I'm looking at the strict definition for IPC, which was centered around healthcare setting or an oral healthcare situation. With our approach of ring IPC, where a case is identified, let's say at home, and because we have a case of Ebola, we now have a team set, the Ring IPC team, to go to the family and make sure they disinfect the homes where every surface where the patient has been to, and also move into facilities around that home to make sure also they disinfect the facilities around that maybe a kilometer around that home, and also do the training. Now this is moving away beyond actually the strict definition of IPC, which was centered around healthcare setting or a healthcare situation. So when we were looking at the definition, we found that was challenging to bring in Ring IPC as part of IPC. Yet we know that it is very, very important in our intervention. Is there anyone who can make a comment on this? Thank you.
Dr. Amani, I think, what exactly was the question?
Oh, thank you so much again. I am saying that when you look at the definition of IPC, it centers around the interventions to avoid infection within the setting of a health facility or within the setting of a healthcare situation. Maybe you have gone for an outreach and a program and then all that. However, when an outbreak comes in, this intervention of Ring IPC, where we go into a home to make sure we decontaminate and screen for other and educate, is an additional reach considering the definition of IPC. Yes. Do we get the sense that actually the actual definition of IPC is now going beyond? We are now going beyond. I just wanted a general comment on that. We had a discussion some time back, and then it was very difficult to match that. Okay, while the definition of IPC is sitting within the healthcare setting, our move into the community for when we identify a case of Ebola to do a Ring IPC at home is still part of IPC. Thank you.
Thank you for the clarification. Actually, this is a really great question. And as you mentioned, Dr. Amani, this infection prevention and control is typically addressed in healthcare facilities or during healthcare activities. But as we know, especially in the case of outbreaks of Ebola or Marburg disease, it's often stems from the community, makes its way into the healthcare setting, and then is often amplified in the healthcare setting. So while we're doing IPC in the healthcare settings, we can't ignore what's happening in the community. And so it definitely has broadened what IPC does, and we do work more closely with communities. And this is why IPC is such a cross-cutting piece of work. It really crosses across many different pillars or elements of an outbreak response. And we have to work collaboratively with everyone involved in the outbreak to provide that support and those resources. And while infection control is focused on healthcare facilities, we can take those principles and apply them to community settings. So I'll stop there because I see Professor Sade has her hand up. I'll let her make the final comments.
Actually, I think you find it, I mean, you said what I wanted to say, that part of the principles of IPC is preventing susceptible individuals from getting the infection. And we recognize that the closer you are to the case, the likelihood that you might come in contact with the patient is high, or that might be a focus. You know, we don't know where the infection is coming from around that place. So what you're doing essentially is protecting susceptible individuals, which Vicky said. So thank you very much.
So thank you so much for that, Sade. I think here we have to wrap up. So I will go back to Dr. Agnes to do the final comments. And thanks everyone for attending today, and to all of our speakers for their participation.
Thank you, Victoria. Thank you very much. As we are coming to the end of our allotted time, I will wrap up by saying thank you very much to all our speakers today, our interpreters today, the WHO colleagues who have worked on this EPI-WIN webinar, Supriya, Jean-Franc, Gabriela, Priya, and team overseen by Dr. Sylvie Briand. Finally, thank you to all of you for coming and for your questions. The recording of this webinar will be available at the EPI-WIN website, and if you want to keep updated on future EPI-WIN webinars, recordings and presentations, and EPI-WIN Digest, please subscribe to our mailing list. Both links will be appearing in the chat. We hope you will join us for our next webinars on Wednesdays. Details will be posted shortly on the website and sent to the mailing list. Thank you again.